Now we have another very good surgeon, Professor Aparajita Chaudhary. She has been my student at MDI hospital, and now she's heading the department. I feel so proud that she's heading, and she'll be doing a great job. Thank you.
Thank you, sir. Very good afternoon. Thank you, AIOS, for giving me this opportunity. I will be speaking on merits and demerits of iris claw lenses. There is no conflict of interest. According to the National Program for Control of Blindness and Visual Impairment, the prevalence of surgical complication is 1.2%. Out of 1.2%, the aphakia is one of them. These are the available options where the sight meet innovation, aphakic lenses redefines the vision. When the lens is absent, that will lead to the visual disturbances in the form of blurred vision, glare sensitivity, and difficulties with the depth perception. These visual disturbances lead to these visual disturbances affect the quality of the life of the patient in the form that will lead to the visual incapabilities, which will lead to development of this frustration, anxiety, and dissatisfaction. The limited corrective measures are available, such as glasses, contact lenses, and intraocular lenses to restore the vision. Glasses and contact lenses has their own limitations in the form of magnification of the images, the limitation of the visual field, optical aberrations, chromatic aberrations, and false projections and all. To overcome these side effects of the glasses and contact lenses, these are the available options for the aphakic IOLs. Either the angle supported IOLs, iris supported IOLs, and posterior chamber scleral fixated IOLs. Among all these lenses, only the scleral fixated IOL available in the foldable form. Rest all are available only in the rigid lenses. This is an algorithmic approach for the selection of correct IOL. In the absence of posterior capsule, in the absence of adequate back support, and if there's no iris support is there, the choice is iris claw lenses. But if the iris tissue is not available, if the little amount of iris tissue even is not available, then choice is scleral fixated lenses. I will be telling about the merits and demerits of the iris claw lenses. This is a comparison table of all the aphakic IOLs. We can see the potential complications are less with the iris claw lenses as compared to the AC IOL and the scleral fixated lenses. And the suitability for the complex cases during the primary surgery, the iris claw lenses are more suitable as compared to AC IOL and SF IOLs. So grip the future of vision with the iris claw lenses. Clarity is at your fingertip. This shows the evolution of this iris claw lenses from iris fixated collar stud lenses to the artisan lenses. We can see as in our previous presentation, sir told about that the iris claw lens is fixated at the mid-peripheral part of the iris of the stroma, which is less vascular and less reactive. You can see all the pupillary muscles, the sphincter pupil and the dilator pupillae muscles are not come in that area. So the fixation of the iris claw lenses are not affecting the iris physiology, and pupil shape is also not altered. The advantage of these lenses these are the small size lenses. The overall length is 8.5 millimeter with the optic of 5.4 millimeter. The lenses are independent to the size of the eye, because it is independent of the cornea white to white measurement and the eyeball size. It can be implanted in any eye, even in a small eye. The only drawback is it is a rigid Palma lenses. Until now, no foldable options are available. As we know, the surgically induced astigmatism depend upon the size of the incision. Since these are the rigid lenses, so minimum incision of 5.4 millimeter is necessary. This can be further reduced by making the scleral pocket incision. Second thing is that shifting of the position of ICL from antipupillary to the retropupillary position. This is a biome picture which is showing that the blue line shows the position of this AC IOL, and the yellow line shows the position of prepupillary or antripupillary ICL, and this green line suggests the position of this retropupillary ICL and SF IOL. We can see when the position is shifting from anterior to posterior, that is more near to the physiological position. So the visual outcome is better with the RP ICL as compared to AP ICL and AC IOL. Optimizing the design from biconvex to the concavo-convex further result in a reduced complication as the concave anterior surface of the lens is far away from the iris. So the complication like iris chafing, inflammation and pupillary block is minimal with this RP ICLs. This is a biome picture which is showing the antipupillary and the retropupillary location of the IOL. We can see in a picture A, there is this cornea is 2.21 millimeter away from the lens, while in the condition of RP ICL, the cornea is 3.33 millimeter away from the lens. The lack of proximity with the corneal endothelium with iris fixated lenses means the retrofixated ICL have less corneal complications like corneal edema, endothelial cell loss, endothelial decompensation as all. While these are all complications are more common with the AC IOL because it is large in size and it is more in contact with the corneal endothelium. It can be used as a primary procedure because it is very easy to place. Sir showed in the previous slides, in the previous videos, it is very easy to place. It takes very less time, so it can be used as a primary procedure. The learning curve is very short. In spite of in the scleral fixated lenses, the technique is difficult and the time it required the suturing. So the longer surgical time is required. ICL is in the combined procedure. If we want to do the penetrating keratoplasty, especially in the case of aphakic bullous keratopathy, in the patient where the deficient posterior capsule is there, the choice is the ICL. The advantage of this ICL is that hypotonic open sky phase is reduced by implanting the ICL, thus reducing the chance of hypotonic maculopathy, macular edema, and corneal detachment. This is the same video which sir showed actually. Not there. Double click से video नहीं चल रहा. नहीं चल रहा. नहीं चल रहा, उसमें है, चलिए कोई नहीं. Okay, sir already showed that video contained this implantation of the ICL in the presence of corneal opacity. The intraocular pressure rise is less with the ICL because of the shape of the ICL. It is a concavo-convex in shape. So temporary rise of IOP is recordable because of post-operative inflammation and retained viscoelastics, which is respond well during the short post-operative period. The SF IOL has a high risk of glaucoma because the SF IOL is supposed to place in the ciliary sulcus, and then when the sutures passes from the ciliary body region, these sutures are retained in that ciliary, or the haptic of this scleral fixated lens remain in the ciliary body region. That will causes a chronic inflammation of the ciliary body, and incorrect suture placement and peripheral enterosynechia are the cause of raised intraocular pressure in the SF IOL. As compared to this AC IOL and the SF IOL, the ICL in the ICL, the chances of IOP rise is very less. In the anterior chamber IOL, the excessive size of the AC IOL give too much pressure to the root of iris, leading to the damage of anterior chamber angle and formation of peripheral enterosynechia. So the study suggests that the chances of rise in IOP in 19% of the patient as compared to this SF IOL, which is in a 4% of the patient, and none of the patient is recorded with the ICL with the concavo-convex shape is not recorded having a long standing rise in the IOP. The iris atrophy at the site of inflammation is reported in the 24% of the retropupillary iris claw inclination. This is a cause of disinclination. As the iris inclination is done at the mid-peripheral part of the iris, which has low blood perfusion and less reaction. But in the long run cases, the chances of this disinclination is there. The tilting and decentration is also noted. This decentration and tilting of the RP-ICL is due to broken haptic, disinclination of the iris tissue due to iris atrophy, improper surgical technique, and the post-operative inflammation and IOP changes are the factors. The study suggests that the tilting and decentration of posterior and antechamber ICL, in both of them, the median decentration is more in the RP-ICL as compared to the antipupillary ICL and the in the ICL. And the same thing, the tilt is recorded more in the antipupillary ICL as compared to the RP ICL. So the tilting is mostly temporal and decentration is mostly inferotemporal. The cystoid macular edema is one of the complication which is generally not there with us, which is minimal among all the available option for this aphakic IL. This cystoid macular edema is minimal with the ICLs. So ICL can be implanted in all the condition where the ACIL is contraindicated, like the congenital axial abnormality, anter-segment trauma, uncontrolled glaucoma, or shallow anterior chamber. The limitation is this: it is a non-foldable rigid Parma lenses and needs sufficient iris tissue for the implantation. So it can't be implanted in aniridia, iris atrophy, and recurrent iridocyclitis. Take-home message is ICL implantation can be done in any eye with sufficient support of iris. Dilatation and contraction of the pupil is not affected. RP-ICL provide better stability and lower the risk of IL tilting, minimum endothelial cell loss with ICIOL, and minimum chance of raised intraocular pressure. Thank you for patience listening.